Tonight's panel is hosted by the ACC, the Arab American Culture and Community Center, in collaboration with the Iraqi American Society, IAS. We are excited to have joining us tonight physicians from MD Anderson Cancer Center to talk about the intersectionality between COVID-19 prevention and cancer prevention. I will let my esteemed colleague, Dr. Al-Amiri, introduce the panel in a moment, but let me for now talk a little bit about what's going on in terms of activities at the ACC. The ACC is currently engaged with the Houston Health Department to advance the work related to addressing the gaps associated with COVID-19 health disparities. Through our community partnership, we work to introduce outreach and education efforts aimed to educate our community members about COVID-19 and address barriers related to misinformation and vaccine hesitancy. Community partners have had the opportunities of partnering up with us at the ACC on educational and programming events aimed at both engaging the community about COVID-19, but also about their general well-being and health. Our programming efforts include panel discussions, community engagements like tonight, offering the ACC as a center to host vaccination awareness events, and many more. In the past few months, we have reached approximately 800 Houston families of diverse race, culture, and socioeconomic backgrounds, working with partners like Amana, and more recently Catholic Charities and Benzina. With this event focusing on cancer prevention with MD Anderson, we want to bridge the connection between COVID-19 and cancer. Research indicates that individuals with cancer are at a higher risk of contracting COVID due to the more susceptible to the infectious agents. As you know, COVID-19 exacerbated the existing healthcare inequities that burden underserved populations, such as Arab Americans, including access to health insurance, employment, and transportation, to name a few. In addition, many have had to shoulder the burden associated with cancer health disparities. With addressing the connection between COVID-19 and cancer, it's also important to highlight the social determinants of health that can provide a more holistic perspective regarding the barriers to health equity. It is now my pleasure to introduce our next speaker and one of our events planners, Dr. Al-Amiri.
Thank you, Dr. Yazigi, and thank you so much for your help. I'm Ali Al-Amiri, the president of Iraqi American Society in Houston, and I have few slides, not more than a few. IAS, or Iraqi American Society, started 2018, and it's mostly a social organization. It's a non-profit organization registered in Houston. It's non-political, and we are Iraqi, we hate politics. And not religious, we didn't hate religion, but we are away from religion because religion divided people, not and also it's social. We lost everything in Iraq after invasion, so we lost families, we lost love. So here we have too many friends, too many people. We are gathering, we get family, and we get also, like a friend, and we are 20 active board members. Our main objective is to unite the Iraqi people in the United States. And it's cultural, like we have gathering, and we have Eid party, and we have all the party. My wife, she's interested to do like a party special for kids. And our dream actually is to start a hospital, clinic, because we know that health is is determinant of activity and we are starting this, and apparently we have too many doctors. They are keen to help us. Education and young people, we are helping the young generation. We have scholars actually every year we have scholars like this year we are increased to 10,000 for those scholars, special requirement. So we are doing a great job. I don't want to take more time. I'm now presenting or introduce our great speaker. First one, Dr. Educator. He is one of the best. Do you know, Eddie, his office is near my office, and I never seen him sitting in the office, to be honest. He is sitting with a patient, and he knows. I never seen him, even one time he entered his office. And Eddie also the first person who, wear the personal protective. When he heard about COVID, he has the hop and he has the gown, and he was ready, and he wheeled the patient. The first patient he wheeled from the ER to the inpatient is Eddie. And he is assistant professor, and he will be associate, and the chair is sitting here. He deserves to be assistant associate this year. And he's director of education program in our department, Anchor Hospitals. He's great in patient care. The other speaker, Mayura Matthew. She is assistant professor and director of inpatient COVID-19 service. And Mayura, one of the best in COVID-19 treatment and education, and she has many publications about COVID-19. And welcome, Mayura, for our program. We start with Eddie. And if you can.
I will just enter.
Yeah.
Which one? This one?
Yeah.
Hello, everyone, and my name is Ed Ketter, and I'm assistant professor at the Department of Hospital Medicine. We call ourselves oncology hospitalist, and it's an emerging and evolving branch of internal medicine practice. And thank you, Dr. Alamiri, for this kind and warm introduction. Thank you. Well, I'm delighted. I'm thrilled, actually, to be here today, and thank you for inviting me for this presentation. And I'm glad to see a decent female presentation present here, because we're going to cover topics about breast cancer and cervical cancer. Before we start, I would say, maybe it's a little extreme to call it cancer prevention. I would say maybe it's a brief introduction to cancer prevention. And before we proceed, I want to summarize types of preventive medicine. We have 4 different types of when we say we want to prevent disease. There are different types of preventive medicine. The primary measures that all patients take to avoid some diseases from manifesting. The most common example for primary prevention is actually vaccination. Secondary prevention steps include detection or early detection of disease and screening tests, and we can, such as blood work, mammograms, pap smears, and colonoscopies. Tertiary, it means measures can decrease complications of disease and restore the patient's function and diagnosis, and I can think of rehabilitation and physical therapy in patients with a stroke. Quaternity prevention includes a collective of health actions that lessen or avoid unneeded interventions of medical care, such as practice healthy lifestyle like diet and physical activity. And for the purpose of our topic today, we're going to focus on the quaternity prevention, and we're going to talk about the primary and secondary prevention in cancer. These are the major points in quaternity prevention I'm going to cover in my presentation today. So we'll start with smoking and tobacco, and we all agree it's not healthy, just to say it simple. So tobacco use is accountable for at least 30% of cancer death, and it accounts also for 90% of all lung cancers. Now, secondhand smoker or people who live with a person or family members who smoke are also at higher risk to develop lung cancer. Now, what is the deal with smoking? There are at least 70 chemicals exist in the cigarettes or cigars or pipe and tobacco. And the problem with those chemicals, and especially polycyclic aromatic hydrocarbons, it can cause DNA damage, and that can lead to cancer. This picture actually just summarizes types of cancer linked to smoking. And smokeless tobacco also can cause cancer, like chewing tobacco. So one of major things is we don't only ask for smoking cigarettes, pipes, or cigars. We also ask for chewing tobacco because it has almost similar risk. What about e-cigarettes? Or I don't know what they call it, electronic cigarettes? Not safe. If you don't smoke, don't start it, and it's definitely not safe for a pregnant woman. The second point is alcohol use, and just to make it simple, the less alcohol you drink, the lower your risk for cancer. These are the cancers linked with alcohol, including mouth, throat, larynx, esophagus, colon and rectum, and liver and breast. Any kind of alcohol can cause cancer, beer, wine, or liquors. Is there a safe amount of alcohol? There is not. You could hear some health organization, or you can read online. Moderation is the key here. They say 2 drinks for a man a day and 1 drink for a woman a day. Does it mean you can have like 14 drinks by the end of the week? No, doesn't work this way. So what is the issue with alcohol? Our body breaks alcohol down into acetaldehyde, and which is a toxin or a toxic chemical compound that can cause DNA damage. And anytime you hear DNA damage, just think of cancer. Next is obesity and cancer. And being obese or overweight is linked to 13 types of cancer, and these 13 types account for 40% of all cancers diagnosed in the United States. A person with BMI, for those who don't know what BMI is body mass index, and you can calculate it by dividing your height in meters by the square of your weight in kilograms by your height by your square of your height in meters. A person with BMI from 25 to 29.9 consider overweight, above 30 or 30 to 40 consider obese. Morbid obesity is BMI above 40. It's a little controversial because I'm sure Arnold Schwarzenegger in his 20s, he had a BMI maybe like 35, but it was all muscle mass, right? It wasn't fat. So BMI is not like definite, it's controversial. Now, obesity, how does it cause cancer? It's complicated. We're going to make it simple. It's triggered chronic inflammation, and the relationship between inflammation and cancer is like chicken and the egg, which one started first. For the next few slides, we're going to talk in details about diet and physical activity. So we hear a lot like, if I stop eating like sugar, if I starve my body, then I can like starve the cancer. It's probably not an accurate concept, because I think of cancer is like the weed in your backyard. Even if you water your grass or you don't, the weed gonna keep growing and gonna like steal all the nutrients from the grass. So that's how basically cancer works. I just want to emphasize there's no food or food group can prevent, not protect, I'm not saying protect, it can prevent cancer. And we're gonna talk about a plant-based diet. And just, it means, of course, beans, and fruits. Now imagine your dish as a circle. You want half of your dish full with green stuff, spinach, salad, romaine, half. And then 1/4 can be complex whole grain rice, beans, and then the other 1/4 you can choose your meat. We're going to talk about meat choices. There are several versions of plant-based diet, but I'm sure most of us are familiar with the Mediterranean diet. And actually it's been published, Mediterranean diet reduces the risks of cardiovascular diseases. And the new researchers at MD Anderson have found that largely plant-based diet may also slow progression of prostate cancer. The other component of diet is antioxidants. Most of us familiar with antioxidants, chemical compounds found in plants, and it protects and helps to repair cellular damage, and it has also anti-inflammatory properties. This is just a slide to briefly summarize if some of you heard of color diet, where you just focus on colorful food, green, such as cauliflower, broccoli, kale, Brussels sprouts, bright red, orange, and yellow food like tomato, sweet potato. Dark purple, of course, eggplant, berries, grapes, and white food. So basically they're telling you your dish should be colorful. Another thing to talk about is fiber diet was recommended, and adding high fiber foods to your diet can help reduce your cancer risk. Now, what are the benefits of adding fiber? First, feeling full longer, weight control, lower cholesterol, stabilize food, blood sugar level, and power. So does that mean you have to be vegetarian or vegan? We're not selling like plant-based diet here. You don't. You need protein for your body to function properly. So, but what kind of protein? The best option would be white meat like chicken breast, salmon, of course, highly recommended. Fish. Can you eat red meat? You can. I mean, it's recommended by our institution, recommended 18 ounce red meat per week. I mean, basically, you would like to avoid red meat. Avoid burning or charring your meat because it could add some compounds that can be cancerous. Eat little, if any, processed meat, such as deli meats, hot dogs, and bacon. And I'm going to show some figures here. As you can see, this is, sorry. This here all healthy and recommended, and this is what we talk about plant-based. Now, someone could argue this chicken could be like full with hormonal injections. It's debatable. Now, look at this here at the top of the triangle. Those are like delicious, tasty food, but they're not good at all. They're all like processed food. I know this hot dog, it's not only probably the hot dog, it's also the bread. It's also ultra processed food. That's carry major risk for cancer. Just briefly give some input on reading nutritional label. You want to focus on servings, the amount of calories. You want to focus how much fat, how much carbohydrates, and sugar. You want to choose compounds or food that's rich with protein, vitamins, and fibers. Briefly talking about skin care, of course, to protect or reduce the risk of developing skin cancer. Anyone, regardless of a skin color, can develop skin cancer. Sunlight, ultraviolet radiation are a major risk. Tanning beds are not safe, and they carry almost same risk as sunlight, so they're not safe. And of course, we recommend to choose sunscreen with sun protection factor, SPF of 30 or greater than 30. We live in Houston. We know Houston weather, so I mean, of course, ideally, you want to wear long sleeves. You want to protect your skin getting any radiation, sunlight, but that's ideal. And you apply a sunscreen like SPF factor 30 or more, like any area of your body will be exposed to sunlight. Again, you can reapply every 2 hours or after swimming or sweating. Tanning beds can cause the same skin damage as the sun, and they are not safe alternative to sunbathing. Some general risk factors develop skin cancer is we talk about sun exposure, tanning beds, age. The longer you live and the longer you're exposed to sun, I don't think you can control how long you're going to live, but you can control how much you're going to expose to sunlight. Having 50 or more moles, that's a tremendous number. But okay, one major topic is physical activity, exercising. Exercise reduces your risk for cancer because it helps to maintain a healthy weight, and it helps to regulate your hormones. Some extra hormones like androgen or estrogen could increase risk of certain type of cancers. It supports healthy digestions. Now, some recommendations from our institution is schedule exercise. Just be serious about it. Plan where and when and how you will exercise. Sit less. I know this doesn't sound like practical. You need, basically, they recommend to take 1 to 2 minutes of walk every hour. Do your best. The American Institute for Cancer Research recommends at least 150 minutes of moderate exercise or 75 minutes of vigorous exercise. That's basically roughly 20 minutes a day, a week, or 10 minutes of vigorous exercise. It's manageable. These two figures just simply, two concepts here. Build up gradually. You don't expect yourself you're going to go to the gym and you're going to run a marathon next day. So you're going to be patient, you're going to adapt a habit. It takes probably maybe 45 to 60 days to adapt a habit. So build up gradually. There's some recommendation. You can start there's a plan for over 4 weeks. The figure on the left is sample of exercise plan. It's just given an input of a schedule for exercising. You could do 30 minutes of aerobics, cycling, walking, jogging, whatever you prefer. Now, strength training. What does strength training means? I'm not sure if you read this, but it's been published lately that people who do weight lifting live longer. Again, you don't have to be a professional weightlifter. You're not Arnold Schwarzenegger. Just do weightlifting. And do it for your own healthy body. You can enjoy more time with the family, right? Instead of spending time in the hospital. What examples are of strength training? Weightlifting, definitely. Also, push-ups, pull-ups, resistance training. I don't have a lot of information about resistance training. They use rubber, right. So, weightlifting, prolonged life. So how it also adds to our topic. It aids your metabolism. It helps you lose weight. It builds up bone density. and it improves and maintains physical function. So now we're going to move into the primary prevention of cancer. We're going to cover two major topics here: human papillomavirus vaccine and hepatitis vaccine. Remember, primary prevention mostly is like to prevent it before it happens. So human papillomavirus, or HPV, it's actually the virus responsible for the vulgar warts, basically. How it spread by skin-to-skin contact. Now, there are like more than 150 types, but there are like 2 types are high risk for developing cancer. Now, why HPV is important? For a few issues. First, 80% of people will have it and they will not know because most of the time it doesn't have symptoms, right? And there is no drug or treatment can eliminate or HPV virus from the body. So when you have it, and most people don't know they have it. Now, what is the relationship between HPV and cancer? So almost all cervical cancers are caused by HPV. So it means basically cervical cancer is preventable. We're going to talk about this. The other major cancer associated with HPV is throat cancer. You all, I don't know if you're familiar with Michael Douglas, the actor. He had HPV throat cancer. The most common HPV-related cancer in men, and women can get it also, and it's just the cancer arises from tonsils and the base of the tongue. Now, about 75% of throat cancers result of HPV infection. Now, is that it? No, we have vaccine. So HPV vaccine, protect your kids. All males and females aged 9 to 26 should get HPV vaccine. Its ideal age will be 11 to 12, they can get 2 doses. Unvaccinated men and women aged 27 to 45 will get 3 doses. It's FDA approved, your insurance should cover it. Now, HPV vaccine prevents, it prevents cervical, anal, vaginal, and vulvar cancer. It reduces the risk of throat cancer in men and penile cancer. The HPV vaccine is safe and effective. The other vaccine or example like relevant to our talk in cancer is hepatitis B. And hepatitis is a medical term. It means inflammation or damage of the liver. Now, the most common type of hepatitis is viral, caused by viruses, and these A, B, C, D, E are the viruses that's linked to the liver. Hepatitis can be caused by other types of viruses, but these 5 viruses are like specific for the liver. We're gonna only cover hepatitis B because it's related to cancer, and it's not a curable disease, and but it's not curable, but it's treatable. So the thing is, if your body doesn't clear the virus is going to stay and keep ongoing inflammation of liver, and eventually will lead to cirrhosis and probably liver cancer. Can you get protected? Yes. There is a vaccine for hepatitis B. And MD Anderson and the Advisory Committee on Immunization Practice and the Centers for Disease Control and Prevention recommend hepatitis B vaccine all infants at birth and to complete 3 doses by age of 18 months. Anyone who is not vaccinated for hepatitis B can get the vaccine. It's FDA approved, should be covered by insurance. We're gonna cover, now this is probably the second major topic of our talk, cancer screening. And we're gonna cover regular cancer screening exam. Okay on time? We're good? Regular cancer screening exams, and saying regular because this, what we're going to cover from now until the end of this talk, only applies to average risk group. We're not going to cover people with family history of breast cancer or family history of colon cancer. I'm going to be quick, cover like the 4 most commonly used screening test. Breast cancer screening exam. Briefly, breast cancer is a mass in the breast or a mass in the armpit, or could be changes in the skin of the breast or any changes on the nipple. The color or discharge or any changes, anything concerning you, check with your doctor. Now, what are the rules for breast cancer screening? Women aged 25 to 39 should get clinical exam every 1 to 3 years, and women aged 40 to 45 should be offered mammograms every year, and women aged 45 to 54 should get mammograms every year. Now, women 55 and older can be offered either every 2 years or every year. Screening should continue as long as women in good health and is expected to live 10 more years or longer. Again, along with regular exams, know your breasts. You know any changes happen to your breast. Other issues, clinical breast exam, we talked, usually done in the clinic by an examiner, visual and touching, looking for lumps and skin abnormalities. Now, you may hear about breast self-exam. It's no longer approved or recommended by any cancer society. Colorectal cancer. Remember, we're doing the screening test to catch cancer at early stage when most of the time they're curable, but they're asymptomatic. There's no symptoms. So some of the symptoms of colon cancer is diarrhea or constipation, abdominal pain, discomfort or urge to have a bowel movement, change in appetite, rectal bleeding, blood in the stool, excessive fatigue, or weight loss without dieting. It's simple. Colorectal cancer screening exam. Basically, all people aged 45 and older should get colonoscopy. It says here 10 years. There's some exceptions. Every 5 years is something to talk to your doctor about. But again, when you're 45 and older, start thinking of getting colonoscopy. Now, your doctor can help you decide if you need to be screened after age of 75. In MD Anderson, we don't recommend screening after age, only for colon cancer, after age 85. Other acceptable options are virtual colonoscopy. It's basically a CT scan be done, then they can construct a 3D images of the colon. If they find a polyps, you're gonna go and get colonoscopy. You may hear or read about this stool DNA test. Now with some techniques we can catch cancer DNA in stool. This test can be done like every 3 years, and when it's combined with fecal immunohistochemical test looking for certain proteins only found in the blood, can be done every year. It could also help to give a screening for colon cancer. Quickly on cervical cancer, remember it's preventable because almost all cases caused by HPV. Cervical cancer symptoms are vaginal discharge, vaginal bleeding, urinating more often, pain during sex, or swollen legs. Any woman aged 21 to 29 should get a pap smear or pap test every 3 years. Women aged 30 to 64, they have few options. They can get either pap smear every 3 years, or they can get it HPV test every 5 years, or they can do co-testing, which is pap smear with HPV test every 5 years. Co-testing is recommended to combine both every 5 years. Women aged 65 or older may no longer need an exam, but discuss with your doctor. Women who had hysterectomy, if they still have cervix, they still need to do screening for cervical. Talk to your doctor about your hysterectomy. If they remove the cervix, you don't need more screening. Prostate cancer, there is no total agreement that should be screened. You can read on urology website different information from American Cancer Society or American Society of Clinical Oncology. Simply, 2 options, checking BSA and digital rectal exam. It's controversial. Talk to your doctor. Don't go ahead blindly check your BCA. It's high, can lead to some invasive procedure you may not need. I want to finish with briefly talk about lung cancer. Any people, smokers, 20 pack a year, which means someone 20 pack a year. Pack a year rate comes with number of packets smoked in a day multiplied by number of years. So 20 pack a year could be 21 packet a day for 20 years or 2 packets a day for 10 years. Men aged 50 to 80 with 20 back year history of back year smoking, and they're still smoking or having quit within 15 years can get a low dose chest CT scan every year looking for or screening for lung cancer. That's going to be the end of my talk. Thank you.
Thank you, Eddie, for this comprehensive. I know the topic is too much complicated, but thank you so much. You did it. Now we are listening to Mayura.
I think they wanted to finish all the lectures and then people can ask questions.
The question after.
Can I take this off of here? Okay. Can I take it off of here? Thank you. Okay. All right. First, I want to thank the Arab American Cultural Center and the Iraqi American Society for inviting Dr. Kader and I here to speak regarding health, which is, I think, every community should do these talks. This is very important information to get to the general public, and especially we're from a hospital with an immunocompromised population, so we see the sickest of the sick patients. So we have a lot of information regarding how to prevent that and how to live a healthy lifestyle. So we're happy to do this talk. And thank you, Dr. Alameri, for inviting us here. Appreciate that. So today, Dr. Kader did scary topic number 1, cancer. I'm going to do scary topic number 2, COVID, since we're getting closer to Halloween. So my topic is COVID-19 updates, Omicron and beyond. And I'm assistant professor in the same department as Dr. Alameri and Dr. Kader. So we all work together in the Department of Hospital Medicine. And I'm also director for our COVID unit. All right, so I have no financial disclosures or conflicts of interest pertaining to this presentation. So I know you guys know a lot about COVID-19 already. We've all kind of lived through this pandemic for 2 years. It's brought us closer together, I think, in many ways. So I'm gonna start off with like a question. How many of you know somebody who's had COVID-19? Pretty much everyone, right? And how many of you know somebody who's been hospitalized from COVID-19? Okay. And then how many of you, if you want to share, have had COVID-19 yourself? Yes. So, I mean, you can see, like, this is a disease that has now become so prevalent in the community. We never would have imagined 2 years ago that this would have taken over our lives, but here it is. So, when did COVID-19 emerge? Back in December 2019, I think we all remember that time when we heard of this new disease in Wuhan, China. It might come across the ocean to us. We should all be kind of thinking about it and scared of it, but we probably had no idea to what extent it would impact our lives. So we went through a series of variants after that. Anytime you have a virus, this can basically mutate into different variants. When the flu pandemic happened back in the 1940s, the exact same thing happened. You started off with the original flu strain, which mutated and became different variants, and now it is the flu strain we all live with, know and live with. So it first mutated into the alpha variant, which was originated in the United Kingdom, and that had about 11 mutations, and then it went to beta, which originated in South Africa, and that had about 10 mutations, and then gamma in November 2020, and then delta. I'll pause that for a second because delta was a huge variant. I think that was the variant that caused the sickest patients out of everything here, even sicker than the original variant. We know that Alpha was 50% more transmissible than the original variant, and Delta was 60% more transmissible than the Alpha variant. So you can see how transmissible it was, and Omicron is the most transmissible out of all of those, and that's why we're living with it now in an endemic phase. So Omicron originated in November 2021. It was reported, I think, widely in many countries at once, but the first reported case was actually in South Africa. And the interesting thing about Omicron is after all these other ones mutated with like 10 mutations, 11 mutations, 12 mutations, Omicron had greater than 32 mutations. And it probably has many more that we don't even know about. So, next slide. So I'm going to talk about a couple things. COVID-19 is such a very broad topic, but we only have so much time, so I'm going to cover two things. One is going to be post-acute COVID syndrome, which I'll go into the definition of that because I think it very much pertains to the endemic phase of COVID and how we're living with it now. So post-acute COVID syndrome, that's what we call it in medical jargon, but in commonality, it's called many different things, and these are the other terms used for it. Chronic COVID, post-COVID syndrome, you might have heard long COVID, but these all basically mean the same thing. You get COVID-19, but then symptoms persist sometimes forever, it feels like. So that's what we refer to as post-acute COVID syndrome. The definition of post-acute COVID syndrome. So as medical professionals, we use the NICE UK definition, that's a society, and they call it a set of persistent physical, cognitive, and psychologic symptoms that continue for more than 12 weeks after your acute illness. And it can't be explained by any other medical diagnosis. So acute COVID, we call that as less than 4 weeks, and then you have this in-between time where you might have ongoing symptomatic COVID, that's between 4 to 12 weeks, and anything above 12 weeks of symptoms, you should call that long COVID. So this is a study I kind of present to our colleagues, but I wanted to show you guys too, just to give you some numbers here as to how many people can actually have long COVID. So this is an international post-acute COVID syndrome outcome study, and it included greater than 4K COVID-19 cases. And basically, the findings that they had were 13.3%, 4.5%, and 2.5% of individuals, respectively, had symptoms of long COVID that lasted for 28 days, 8 weeks, or greater than 12 weeks. So you can see that quite a good amount, 13.3%, actually had symptoms that lasted greater than 28 days. They did find that higher the age and the more number of symptoms that you had during your acute illness, the more chance you had of developing long COVID. So the incidence of long COVID in this study was estimated to be around 10 to 35%. I say 10 to 35% because I included some references for some other studies there too. So if you guys want, you can look at those. And it may even reach up to 85% in patients that were actually hospitalized for COVID. The things that make you at high risk for developing long COVID are your pre-existing medical comorbidities. Things like asthma, COPD, things like cancer, diabetes, heart disease. If you have a history, medical history of these things, they all put you at higher risk. And also, if you needed hospitalization for COVID, there's a good chance that you're going to have some persistent symptoms afterwards. If you required oxygen therapy at any point, there's a good chance that you might have long COVID. And then there's a separate bucket under the term long COVID, and that is called post-COVID neurologic syndrome. And you might have heard or you might have experienced yourself or your friends say after COVID, hey, I have this brain fog. I can't remember things. I can't do things as quickly as I wanted to before. I don't feel myself. And those symptoms might persist for a very long time. They can sometimes persist up to months. And there's really no known good treatment for it. But just like long COVID, these symptoms are born out of higher severity of acute illness. So if you've had a much more severe COVID course, you're more likely to get something like this. So in this study, they looked at a bunch of patients, 236,000 COVID-19 survivors, and they looked at the incidence of neurologic and psychiatric diseases in the 6 months following acute COVID. And they noticed that 33.6% of people, that's a huge amount, actually had some type of neurologic complication. Like, why does this happen? And we don't know exactly, but we think it's because COVID-19 pathophysiologically actually impacts your blood vessels all throughout your body. It causes inflammation, it can cause blood clots, it can cause micro blood clots that you might not even know about. But these things, blood is the one system that runs through your entire body, right? So you can have many systems that are affected. Your bloodstream runs to your brain too, and if you have microclots or you have inflammation in your blood vessels, that can all lead up to all of this. Anxiety and depression were probably the most common occurrence of neurologic and psychiatric manifestations, with 17.4% incidence in the overall population, and then for those patients admitted to the ICU, it was higher a little bit, 19.2%. I know this is a little bit small for you guys to see here, but I wanted to point this out because this is hot off the press. This study was published yesterday. So I found it and I just kind of added this slide yesterday. But this was a study led by senior author, Dr. Ziad Al-Ali. He is one of the premier authors over in Washington University. He has done, I kind of follow him because he's done so many studies on COVID-19. He's a clinical epidemiologist, and he's, throughout the pandemic, published, I think, probably hundreds of studies on this. But this was the latest, and it's a federal study published in Nature magazine, and it included 150,000 US veterans who tested positive for COVID-19. So they compared those patients, 150,000 patients that tested positive for COVID-19, to records of 5.6 million patients who did not test positive for COVID-19. And then they also went back in time, pre-COVID, 2018 to 2019, and they looked at another 5.8 million patients. And they compared neurologic outcomes of all these populations. So what did they find? When they accounted for confounding factors, they actually found that out of those patients, 77% of patients with COVID had a higher risk of memory problems. 80% were more likely to have seizures. 50% were more likely to get a stroke. 43% were more likely to have mental health issues down the line. 35% were more likely to have chronic headaches, and 42% were likely to have movement disorders like chronic tremors. These are huge numbers to me, and all these numbers, and I have a neuro, I know, for you especially, but all these numbers are following the 1 year post-COVID. So I don't know what happens after that 1 year. I don't think any of us really do unless more studies come out, but this is that 1 year following COVID. That was my intention. So I'm from a cancer institution, so of course I have to tie in cancer and COVID. So I have just a couple studies on that from our institution. And I know Dr. Ketter's on a bunch of these studies too, so he might recognize some of them. So we looked at long COVID in cancer patients. So how does long COVID look like in the sickest patient population? So we looked at cancer patients between March 1st, 2020 and September 1st, 2020. And basically, patients that were COVID positive, they were followed for about three months, and they were sent daily questionnaires for a certain time period. About 312 patients were included in this study. And with those questionnaires, they learned that 60% of these patients actually reported long COVID syndrome. So 60% of the sickest patients in the world reported long COVID syndrome. 75% of these patients were solid tumors, and then the others were like hematologic malignancies like lymphoma, leukemia, things like that. The most commonly reported symptom was fatigue. The second most common was sleep disturbances, and then things like myalgias, which means muscle pain for a long period of time. Some people had GI symptoms like chronic nausea, diarrhea, and that was up to 61%. And then there was a lot of people that had altered taste and smell too. Close to 50% of people had altered taste and smell up to 3 months and probably longer. And then chronic cough up to 3 months was reported in 46%. And actually a higher number of females actually reported these symptoms with real clinical significance, 63% of females versus 37% of males. So the incidence was much higher in females. Development, this is also another study led by our ID docs and pulmonary docs at MD Anderson. So this looked at 609 cancer patients that were hospitalized with COVID-19 for the course of 1 year. And out of those, they had to pick out some that actually could be included in the study. So 98 cancer patients and 75 non-cancer patients were actually seen in post-COVID survivorship clinics. Because long COVID is such a prevalent thing, we actually have a post-COVID survivorship clinic at MD Anderson. So these patients were referred to that clinic 3 months post-discharge and then 6 months post-discharge too. And we looked at how many of these patients got interstitial lung disease. Interstitial lung disease is a type of disease that can happen for multiple different reasons, but we found that it does happen with COVID-19, and it's basically almost leading up to scarring of the lungs. So if it persists for a long time, it can become irreversible. So we saw how many of the patients actually developed irreversible versus reversible lung disease. So the first group was 20%. Those were the patients that were asymptomatic. They didn't have shortness of breath. They didn't have a chronic cough. And they didn't have any ILD. They were good to go. They didn't have any post-COVID lung symptoms. Group 2, they were symptomatic. They might have had a cough. They might have been short of breath for a long time, but they never showed ILD on their CT scans, follow-up CT scans, 8%. Group 3, they had ILD, but they had spontaneous improvement on their 6-month follow-up CT scans. That's 43%. That was our highest cohort. So that's actually a good thing. They had persistent symptoms, but it actually resolved at 6 months. And then group 4, they had persistent ILD at 6 months. So that is going towards irreversible disease. And that was 25% of the cancer patients developed irreversible lung disease. And then you can see the numbers among non-cancer patients, because we did look at those too. The numbers are a lot less. Group 1, 3%, 2, 4%, and group 3, 35%. And those that developed persistent ILD, group 4, was only 19% compared to 25%.
ILD means pulmonary fibrosis.
Correct.
Fibrosis of the lung when the patient walking with shortness of breath.
Exactly. So now that I told you how about all the scary stuff, how can you prevent the scary stuff, right? How can you prevent COVID-19 and the risk of complications? So you must vaccinate. Prevention is the best way to go. And if you've all gotten your like primary vaccine series already, I applaud you. Okay. So here are some of the vaccines available in the US. So you guys probably know about all these and might have been reading in the news about them. We have the Pfizer, BioNTech, Moderna, Novavax, and Johnson & Johnson. The only thing I want to point out here is that the top three are all like mRNA vaccines. That's the new modern type of vaccine that we've been using for COVID. And then the Johnson & Johnson is different. It's not an mRNA vaccine. It works differently, and it's not a like 3-shot series like the rest of them. So we actually, through data that we've found, we actually recommend probably the top 3 more frequently than we do Johnson & Johnson, just because they've had better outcomes with preventing COVID. And also Johnson & Johnson is really only recommended in situations where people have had an allergic reaction to the other 3, or they're at a risk of adverse events from the other 3. The only other thing, okay, I can go into that on the next slide, actually. Okay. So this is kind of tiny too, but you'll give it to them for reference later, Dr. Alamary. But this is taken straight from the CDC website, even if you don't get this PowerPoint. But this is the vaccine schedule that's recommended here in the United States for both adults and children. And you don't have to like memorize this, but easy way to look at it is the 3 top vaccines that I told you about a little bit earlier, and that all of the primary series vaccines that most people have gotten, I think already, are recommended for pretty much all the patients 6 months and older at this point. They're approved. And these are all 2-shot series, with the 3rd shot being a booster. Okay, it's supposed to boost your immune system. And most of these are given either 3 to 8 weeks apart or 4 to 8 weeks apart. The Janssen vaccine I didn't put on here because it's a secondary recommendation, and it's only recommended for those 18 and older. It's not approved for the kids. And and then I'll go into like the new booster in a little bit. All right. All right. So you might be concerned about like vaccine side effects. What are they? If you haven't gotten a vaccine, what should you be concerned about? What could happen? I just want to start out by saying severe reactions to vaccines are extremely rare. They definitely happen, but they're extremely rare, and it's so difficult to predict in who it could happen. The highest risk you probably have with the mRNA vaccines is something called myocarditis or pericarditis. It just means inflammation of your heart or your heart sac. And that can happen with mRNA vaccines. It's most common in teenage and middle-aged males. But the risk can actually be reduced when we give vaccine number 1 and vaccine number 2 further apart. So if we know that somebody's at risk for it in that age group, we can consider a different vaccine timing interval. And then actually it's most commonly been reported in those that received the Novavax vaccine. There's also a potential cause and effect relationship between the Janssen COVID-19 vaccine and a rare but very serious adverse effect. It's known as TTS, thrombosis and thrombocytopenia syndrome. It means it's kind of weird. It means your blood is too thin at the same time as it's forming blood clots, essentially. But it occurs at a rate of only 4 cases per million, 4 per million, so you can see how rare it is. but when it does occur, it will most surely result in death. All right, and I wanted to put a spotlight on vaccines and women's health because I've just received a lot of questions on this previously. You know, what impact does vaccine have on pregnancy, lactation, fertility? People were really concerned about that initially, and I think still, especially with the new booster coming up. So we actually recommend vaccination in all of these groups. Those that are fertile and looking to get pregnant, those that are already pregnant, and those that are lactating. We haven't found any significant deterrence, any significant risk that outweighs a benefit. And actually, pregnant people and recently pregnant people for up to at least 48 days following their pregnancy, if they've had COVID-19 during that time period, they're actually at risk for severe illness and death when compared to non-pregnant people. And I've seen that personally. 2 of my pregnant friends in my age group actually passed away from COVID-19 during the 3rd trimester of their pregnancy. So I know that can happen, and it's been reported in literature too. So like I said, the risk of the vaccine is not as much as the benefit, okay? And then pregnancies that are affected by COVID-19, those babies are also at risk for preterm birth and stillbirth. So it does affect the baby as well. And the benefit of vaccination, like I said, outweighs any risk. Same for lactation. We know that the vaccine antibodies can be passed through the breast milk. So you can actually confer protection to the baby. We don't know how robust the protection will be. We don't have data on that yet, but you can confer some degree of protection. And same with pregnancy. If you're a vaccinated individual and you give birth, there's a good chance you transmit antibodies to your baby too. And then fertility, I think there's been some studies done on this. None of them show any evidence that vaccines at all in general, and then including the COVID-19 vaccine, cause any issue with fertility. So the new booster, so this is what's kind of been in the news the last couple weeks. The new booster is what we call a bivalent vaccine. It's different than the previous 2-3 vaccines you've received before. Because bivalent, because bi means 2, half the vaccine targets the original strain that we talked about that originated from Wuhan, and then the other half targets the most prevalent strain in the community right now, Omicron. And they took the 2 subvariants that are circulating right now, BA4 and BA5, and that is your booster. So that's supposed to give you even better than immunity than the vaccines that you've had before. So safety of this, they actually have not done robust human testing. They've only done mice testing, and the mice tolerated it well for this vaccine. But they did take the safety data from Pfizer and Moderna and compared it to what they were putting out with this vaccine, and it seemed relatively safe. It did go through robust FDA approval to get here to us. So the timing between boosters. So if you received your original vaccine series already, you received dose number 1, 2, and maybe you received the 3rd booster, you need a minimum of 2 months between that series and getting this booster. And it is also recommended you can go up to 6 months. And actually, some studies have found that if you wait longer between 2 different vaccines to be given, it actually confers better immunity to you the longer you wait, because antibodies in your body wane over time. So if you get a booster right as they're starting to wane, your immunity will go up. And that's how that works. But they say don't wait greater than 6 months because you'll have no immunity at that point. Timing between booster and a recent COVID infection. So if I'm infected from COVID today, I have to wait. They recommend a minimum of 4 weeks or until my symptoms resolve. And then the optimal recommendation is that they say delay your next vaccine dose by 3 months, because you probably already have some immunity from that COVID-19 infection, and then you can wait till 3 months to get that booster when your immunity starts waning, okay? And then reinfection, it's possible, you know, following a COVID-19 infection in the weeks following it, but it's pretty rare. And I think, so are vaccines beneficial? Heck yeah, vaccines are beneficial. I think we've seen that through the COVID-19 pandemic and how greatly deaths and mortality was reduced over time. The reason for that being vaccines, really. We didn't see deaths start to go down until after January 2020, and these vaccines came out, I think, in 2021, I should say. These vaccines came out in November 2020 and December 2020. So the two things I want to point out most here that is the influenza pandemic. When the flu first came out in 1943, before vaccines, 21 million people died worldwide before they came up with the flu vaccine. After the flu vaccine, they only saw 8,000 deaths in that following year. Sorry, not in the most recent years. And then the second one that's like very stark contrast was polio. So polio, 15,000 people, before the polio vaccine, 15,000 people used to get paralyzed from polio each year. After the vaccine, there have been 0 cases, at least here in the US, since 1979. So that's like very wondrous to me. So you can see how beneficial vaccines have been in the past. Though we don't have long-term COVID data, I think we will in the 10 years following now. And you will see the same trends that we saw with all these other vaccines. So I encourage you all to get vaccines and encourage your family members and friends to get vaccinated for these vaccines, as well as the ones Dr. Ketter talked about, because prevention, that's the best thing you can do for your health overall. Thank you.
Thank you, Mayura, for this comprehensive, actually. There's something I didn't know, so, but she scared us. I don't know. If one got the COVID-19, he should be scared.
I just wanted to let you know that GEL graciously extended the time, because we are lacking a little bit about the time, but she graciously extended the time so we can stay until 9. But definitely we would like to have some question. But just in case before you leave, I would really like to thank you so much for supporting the collaborative effort and for hosting us to the Beit al-Arab. Thank you so much, your time and dedication, and we look forward for the future collaborative. I have to thank Jill because she needs to leave. Are we accepting question? Are we taking question? Okay.
A question for...
Yes.
For how long the booster will last?
Thank you. So the booster is expected to last at least up to 6 months, just like the previous vaccines did, but we won't know until we have further data because we haven't really trialed it on humans. We're hoping this one, since it's a bivalent vaccine, lasts a lot longer. But very well, we could be in a situation where we're getting annual COVID vaccines like we were flu vaccines.
Mayura, do you think that, as a scientist, do you think that possible the vaccine has some side effects later on people, like encephalitis or dementia?
Yeah. No, that's a good question. And honestly, I'll have to be honest and say I don't know, because mRNA is such a new technology. There's been nothing in vitro, like in the lab, to suggest that it's going to have long-term implications. And I think if this works out well for us in the next 5 years, mRNA vaccines are going to be like your future forever.
What about the children?
We have not seen very many in children. We've seen some like MIS, multi-system inflammatory syndrome, in children, but it's been, it's been like that one case where I said it's 4 in 1 million. It's been very rare.
As we know, we are approaching winter, so we have flu vaccine and the COVID vaccine. So I have 2 questions. One of them, can you take them, both of them, at the same time, next month or not? The second question, I will ask you about the flu vaccine. As long as you're expert, there's 2 kinds of flu vaccine now, Sanofi and the other one, which regular. Which one you recommend, and what is the difference between them? I'm sorry to ask you this question of the subject.
Good, very good question. So as far as the differences in the flu vaccines and the brands, there's no difference. So how our flu vaccine in the US is formulated is actually Australia's season for flu is ahead of ours. So they look at the flu strains out in Australia and maybe some other countries, and they formulate our flu vaccine based on what strains have been prevalent that season. So whatever vaccines are here in the US, they use the same technology. It's just a company difference, really. And then your first question, I would say get a jab in each arm at the same time. You can get the flu vaccine and you can get the COVID vaccine at the same time, but the only thing you're gonna suffer is if it brings on side effects like fever, headaches, you might get a little bit more than if you just got one, but there's no data to show that you can't get both. I've been telling my family members just to get it at least a week apart just to avoid that increase in symptomatology.
Question to if people get scared from corona, and what is the next safe procedure they can do or option?
We thought there are 2 options available. The visual colonoscopy, you can do low-dose CT scan.
Is it approved, FDA approved?
I don't think it's FDA approved.
Yeah, so.
It's an
Yeah, I think I will ask a question about that. I don't know how to speak. About just like a comment. For instance, I have a positive family history of colonic cancer in my aunt, the first relative. She was in her 70.
She got it, she was 70.
65, yeah. I don't believe it was advanced when she was she didn't stay 1 year and then she died after that. So what are the if I don't want to do colonoscopy, is the other alternative are okay, or I have to do the colonoscopy? It's a hard question, but
I think you have to do a colonoscopy.
okay.
And they just put you to sleep and you'll wake up happy. I mean, I had a colonoscopy. It's no big deal.
Yeah, I'm scheduled, so I'm just.
No, I think colonoscopy.
I want to ask you about the treatment, the new medication for COVID. What do you think of it? Many people not welcoming. So, this is the first one.
You have another question?
No, let's have it.
I just want to confirm, are you talking about Paxlovid, like the pill? Okay. Yes to it. Yes, Dr. Ketter and I think we've treated multiple, probably hundreds of patients at this point on the COVID unit with Paxlovid's IV equivalent, remdesivir. It has good outcomes when used early on. So there's 2 phases of COVID. The pulmonary phase, which is the lung phase when it starts to attack the lungs, and then you have the viral replication phase when the virus starts to replicate exponentially. any of these medications that you get, they are only effective if you're going to give it in the initial stages, the viral replication phase, to decrease the amount of viral replication. So then it decreases the amount of disease severity. But it's a good pill. My own parents have taken it, and they're both high-risk immunocompromised patients. So when they got COVID, they took it within the first, I think, 2 days of symptom onset. And they had really severe symptoms initially, and they saw the difference within 48 hours. Yeah.
You know, the COVID virus is have many variants all the time. It's changed. So the booster dose, I don't know. Like you have the vaccine like the company give it for this variant. After that, there is a mutation and people taking the booster dose. So I cannot understand, like, because it need at least 6 months from for the company to have a new dose for the new variant. So what's the benefit of the booster dose? I couldn't get it.
I'm glad you asked that question, because I think that question is probably on everybody's mind, honestly. That's a very good question. If this virus keeps mutating, and what are we just going to do? Get vaccines every 3 to 6 months? And we're probably behind the ball, right? Because the virus is mutating at a faster pace than we're making vaccines. So to answer that question, the good thing is we've seen with all those viruses in the past, flu, measles, mumps, rubella, everything, the strength of the virus actually wanes over time. It gets weaker. As people start to live with it, and as our own body's immunity starts to adapt to it, the virus actually has less of an effect on our body. So I think in the future, like a few years from now, that's what we have to look forward to. It's going to be the common cold, whether or not you get the yearly vaccination that they recommend, or every 6-month vaccination. So you just have to be okay with living with mild symptoms, I think. But at this point, we are just now coming from pandemic to endemic phase. We're just now getting out of pandemic phase. So I would say none of us are fully protected yet. None of us have developed that immunity and strength quite yet. Some of us might have it more than others. But I would get this vaccine at least. So why get it?
For the 2 vaccines, it's okay. It was a very severe attack. But now, if we balance between the severity and I think it's better without, like, why we have to take something in our body which is still under testing, and they are still don't know the side effects.
Yeah.
If the virus is spread, not that it's wrong.
I have a good answer for that. It's because we have to think selflessly. And if you think selflessly, we're actually doing it for the greater good of humanity. Because if we thwart this virus now by giving vaccines broadly, that virus will wane over time. It's not going to affect us. But without vaccination, like if none of us got the first vaccine, or less than 20% of us got the first vaccine, we would have a really, really high mortality rate right now in this world, especially with that Delta wave that came on. If we had not gotten vaccinations, I think a good half of the world probably would have been wiped out, honestly. Like that would have been one of the apocalypse.
You don't think that this vaccine stimulate the immunity system in our body and tackle anything else from that point of view?
You said, does the vaccine tackle the immune system?
Encourage the immunity,
Mm-hmm.
body response.
Yeah.
Stimulated.
And does that cause any other side effects? Yes, it does. Yes. So when you are trying to boost your immunity, certain side effects can certainly come with that. And I think that's what we saw in some of those rare side effects, like myocarditis, because there was such an immune response, the whole heart got inflamed, the heart sac got inflamed. It happens in a set population, but certainly, yes, it can happen when we're doing that. It's rare, though.
So I have a question to Dr. Ed Kader. Am I pronouncing your last name correctly? Yes. Hopefully I don't sound ignorance. Did you say something about there is a vaccine for cancer? The H?
Basically, there is a vaccine for a virus, or a cancer virus that can cause cancer. It's a human papillomavirus. The vaccine I spoke about target human papillomavirus, and almost all cervical cancer cases caused by human papillomavirus. So basically, if someone or a female at a certain age, preferably 9 to 26, get the vaccine, it's been published, like these populations who got the HPV vaccine, they witnessed way much lower rate of cervical cancer. So yes, it can prevent cervical. Now, is there a vaccine for cancer in general? There are clinical trials. It's still like a lab work, it's still subclinical, it's still in mice, but I think the future carries all like possibilities. So I think at some point we will witness the evolution of cancer vaccine. Yeah. Not yet, though.
Regarding the neurological, like memory issue and dementia, actually in elderly people. Actually, I noticed them in some of our, I deal with some medical students, and I think some of them, they got the virus, and they're complaining about this, the brain fogginess that we see in patients who have immune reaction, like MS patient, for instance. All those patients, even very high performance people, they start noticing that there is a decrease in their rate, their task they do. They usually, I used to finish my task in 2 hours and I need 4 hours now. Also, like the disease effect, I don't know what the long term, if this will increase the risk of dementia in the coming generation. I'm not sure how long it's going to last, because we don't have the data about it. Actually, there is a recent study that showed that there is patients who are elderly patients who had the COVID. I don't believe that it is regardless the severity. They are at higher, they are developing dementia symptoms earlier. Not sure if it is from the encephalitis that happened, was subclinical, or I'm not sure what the result, but I think maybe we don't know. Maybe data will bring more.
Yeah. I mean, definitely, I'm looking forward to that data. You said the word encephalitis, and I just want to point that out because this brain fog that people are getting, it's been compared in literature to limbic encephalitis. And for those of you that don't know, our limbic system, it includes multiple areas of our brain, but with regards to this, it includes a place in our brain called the hippocampus, which is responsible for memory, and it also includes a place in our brain called the amygdala, which is important for our responses, it produces fear, pleasure, things like that. Yes, exactly. So then when you see somebody have this post-neurologic syndrome, they have higher anxiety, they have higher depression, and things like that. And that's because the limbic system is inflamed. And there's been, I think, at least a couple of studies where they've seen that inflammation on scans and stuff go down over time. But I don't think we have a good answer. There was a podcast that I've seen with a specialist on this. I think it was in the Mayo Clinic in the past, where he said that basically only patients that are already have an underlying predisposition to Alzheimer's prior to COVID. This COVID might throw them over the loop into getting Alzheimer's quicker, but otherwise, just because you had COVID or brain fog, you're not at higher risk for developing Alzheimer's.
She doesn't know
Okay. I was asked to come in the middle. Okay. My name is Randa Umran, and I am one of the board members of Iraqi American community. I have few minutes to end this event, and I will begin by expressing my deep appreciation for the speaker for taking the time and effort, putting the slide together, and awesome information, and for taking the time out of your busy schedule and come to present to us. I think it puts a responsibility on our shoulder as a leader in a community that we need to do more of educating the community about the fact that you just have mentioned. The thing that I like is about weightlifting. I said, yes. You know, I would tell you something funny about me. I signed up for a gym, and it happened that gym has a lot of weightlifting. So I didn't know about that. So I am improving, but I'm still in the stage of just lift the dumbbell, which is, I think, still count. أريد أشكر يعني شكري العميق والامتناني لأنه أنتم حضرتوا هاليوم. شكرا جزيلا، وأكيد أخذتوا من وقتكم. Of course. وشكرا جزيلا الفولو مالتي بالعراقي امريكان بورد ممبر. بدونكم ما كانت راح يصير هذا الايفنت ولا راح ينجح. و specifically for the leadership for Dr. Ali. احنا عندنا شويه ريفرشمنت وشاي وقهوه، فتفضلوا، ونتمنى انه نشوفكم بالحلقات النقاشيه الجايه. شكرا.